morning, everyone. Welcome to our Thursday HIV Center Rounds. We're really excited to have our guest speaker today, who is a friend and colleague who recently left Columbia. But let me give you a heads up on the next grand round, next HIV Center Grand Rounds in April is on April 18th, and it's one of our duo of our postdoc research fellows, Drs. May Tan and Kirsty Sivright. May Tan will be presenting on culture and cognition, examining children's cognitive and academic development in rural Zambia and beyond. And Kirsty will be presenting on family and household factors related to HIV self-management among adolescents and young adults living with HIV in Zambia. So, you know, a good, nice duo that are somewhat related to each other. And then I'll give you a heads up on our 2 grand rounds scheduled for May. On May 2nd, we have Dr. Jerome Singh, who will present on research gaps and associated ethical legal challenges in high-burden HIV settings in Africa. And then on May 16th, we have Dr. Amanda Castell from George Washington University, who has yet to give us her title, but many of you know her, and Amanda is always a wonderful presenter. Okay, so without further ado, since particularly since we're starting a little bit later from our normal time today, but we still have plenty of time, I'm going to introduce today's speaker, who is Dr. Morgan Philbin, who is an associate professor in the Division of Vulnerable Populations at the Department of Medicine at UCSF. Dr. Philbin got her PhD along with her Master's of Health Science at Johns Hopkins Bloomberg School of Public Health. You know, Morgan, it seems like, my God, only yesterday when I recall meeting you at Hopkins. I think it was in 2013, just before when we spoke about the postdoctoral fellowship here at our HIV Center. And it doesn't seem like it was 11 years ago, but I guess it was. And then, as I mentioned, Morgan was with us here at Columbia. She did her fellowship with us between 2013 and 2016. And then she was in the socio-medical sciences in Mailman here as an assistant professor up until December of 2022. And as I said, she's now at UCSF. Morgan has worked in the field of social and behavioral science for 20 years, conducting mixed methods research that explores how multi-level factors influence how people with HIV progress through the HIV care continuum, with a particular focus on women and sexual minority individuals. Among many other awards and acknowledgements in 2021, I just want to highlight she received the Early Stage Investigator Lecture Award from the NIH Office of Disease Prevention for her work on biomedical HIV treatment and prevention. So her topic today, and you know, Morgan is leading studies right now on developing a patient decision aid to help women with HIV and their providers choose between oral and long-acting ART, and also a study on looking at women's interest in long-acting ART among women in the South, with a focus on developing other tools to support this uptake. So today she's here to talk with us about the scale-up of long-acting injectable ART in the United States and mixed methods insights from providers and women with HIV. Over to you, Morgan.
Awesome. Thank you so much. And it's been so fun just to see like names pop up on the participant list that I recognize. So I really appreciate it. And thank you all for being flexible on the start time. Waking up at 5:30 was like fine, but being cognizant is a different thing. So, if there's some word stumbling, please forgive it. Caffeine's like kicking in as we go.
Well, we appreciate you doing this at an ungodly early hour for you. So thank you.
Oh, it's totally fine. It's totally fine. Hopefully you can see the screen. So first, like I said, I'm just like, it's really fun to see all the names pop up, to see Bob. Claude and I were texting this morning. So there are obviously like just too many people to thank from Columbia in general, and the work presented here, though I hope I remember to name everybody in the acknowledgement section. So I'll just focus on this presentation and really thank Claude for inviting me and Bob for that kind introduction. So I'm going to use this talk as a way to give an overview of the work I've done over the past 5-ish, although some of the preliminary work goes back longer than that, years focused on the long-acting injectable ART space. So it's going to be a bit higher level. just meaning I'm not going to go into the weeds of the methods, but I'm happy to talk more about those during the Q&A because I sort of wanted to do more of a where we are right now. So briefly for the presentation, I'm going to start just going over some background to make sure we're all on the same page. Given that this is an HIV center, I'm definitely, I think most of you already know much of what I'll present. I'm going to share some quant data from Women in the MaxWise, which I'll describe, although I know many of you know the study and some have worked with it. And then share data from some qualitative interviews we did with HIV clinic providers. And then I'll talk about sort of where we're going from here. And then briefly mention some work that I'm doing on long-acting injectable PrEP. And then just wrap up with some concluding thoughts. So to start, just to make sure we're on the same page, and it's interesting, actually, those of you who know me at the HIV Center, I focus primarily on adolescents, a lot of primarily sexual minority men. And then over time, I've ended up moving more into women's health. And so I realized I actually didn't know the stats for women when I started in this space. So about 20% of people diagnosed with HIV in the US are women. Unfortunately, 2019 is the newest stat that we have for yesterday on the CDC's website when I was checking to see if it had updated. But just to share, some of the care continuum outcomes, much like the general population, are still far from ideal. So only about 3/4 are receiving some form of care, a little over half are retained in care, and then 64% are virally suppressed. So there's still a lot we need to do to get to not just the goals, some of the 95, 95, 95 goals, but just to make sure that there really is equitable access for people that need it, both for their own benefit and for that of the public's health more broadly, which is why some of the new drugs that are coming online in terms of long-acting injectables are actually really, really exciting. Sorry, I don't know if you can hear it. There's like a torrential downpour going on, which as a Californian makes me really excited to hear rain. But if it's loud, I apologize. So long-acting injectable ART, as many of you know, is based on 2 intramuscular injections. So if somebody goes in, they get one in each butt cheek. It's cabotegravir and rilpivirine. When they did the clinical trials, it was non-inferior to oral ART. And so based on that, the US FDA approved it in 2021 as a 4-week dosing pattern and then an 8-week dosing in 2022. And I do want to flag this is for people who are virally suppressed. That's still what the label is. Although studies are now showing success among people without viral suppression. There's been some work that Monica Gandhi is doing at UCSF where they did find they had a high success rate of starting on long-acting ART among people who are not virally suppressed. So these studies are pretty small. They're under 100 people. But anecdotally, talking to a lot of providers, they're already making that shift. One thing I do just want to flag, a lot of these trial participants were primarily men. So usually 20 to 25% were women. And that also meant the trials, not only were they mostly men, they did not include pregnant people. So that has large implications for women of reproductive age, which I'll talk about a little bit later, but just wanted to flag for you. Long-acting ART was well tolerated and preferred. You'll notice I bolded it by clinical trial participants. There's a reason for that. We're seeing disconnects between what people in trials said they wanted and their experiences and what we're seeing in quote unquote the real world. Obviously, we know there's a lot of regulations around who can participate in a clinical trial, which is probably driving that. And then overall uptake in the US has been slow. Obviously, there's no perfect way to measure how many people wanted it, who's gotten it. Luckily, I was able to, through some colleagues, talk to some folks at ViiV, and they said by December of 2022, there were 15,000 people in the US on long-acting ART, and by December of 2023, there were 26,000 people. So, okay, that's, an increase from year to year, but still, if you think, there are over 1 million people in the US with HIV, and 26,000 are on long-acting ART, it's not making a huge dent at this point. I mean, I have no doubt it will increase, but just to share that uptake really has been slow. Also, for those of you that know me, you're not going to be surprised by this soapbox I'm briefly going to stand on, but it is, while this is changing, it is primarily approved in North America and Western Europe, although the highest burden of HIV, as we know, is in sub-Saharan Africa. Many of the trials are done in the global South, and so it is something I think we really need to think about as HIV researchers, is that tension between where trials are done, whose bodies these studies are done on, and then who gets access to these drugs. So one of the things I briefly wanted to highlight is the preliminary research that led to this. And this actually started, I was trying to think of when these initial seeds were planted for this. And it was either 2014 or 2015, which was when I was a postdoc. So obviously things do take a while, but it's exciting to think of sort of when we started thinking about this space. And so as part of the postdoc, we started thinking about, okay, this looks like we're going to have some long-acting injectable medications coming down the pike. So what do people think about them? So we ended up doing qualitative interviews, about 90 interviews across MaxWise sites, which I highlighted the 6 states here, or the places I should say where we did them. And it was Bronson, Brooklyn. So there were 2 sites in New York. This was done from 2017 to 2018, so well before approval had happened, since approval again was not until 2021. And like I said, we did 89 interviews. About 2/3 were women with HIV, 1/3 were women without HIV. And we were really interested in just their general thoughts around barriers, facilitators to long-acting ART and long-acting PrEP. Excuse me. And one of the main things that came up around barriers was there's just this fear of new products. And even if they said, listen, I went through clinical trials, it's like, I want my friend to do it. I don't trust it. This was particularly salient among women in the South who, where there's more of a history of forced sterilization campaigns. There was a lot of fear of side effects. You take a pill, you have a side effect, you don't take it the next day. If somebody injects something into your body, you can't take it out. And then medical mistrust. And then standard challenges like transportation. If you have to go to the clinic every month for an injection versus getting pills delivered by your pharmacy. And then issue of pregnancy, because pregnant people are not included in the trials. And then in terms of facilitators, people really had this idea that shots are more effective than pills. I mean, the trials didn't bear that out necessarily, but there really was this idea that it's more helpful. It goes straight into your blood. Discussions of ease and convenience. They're like, I can tell someone I'm going to the doctor for whatever reason I want. And then this increased autonomy and confidentiality, because they're like, friends come over, they're nosy, they look in your medicine cabinet, but, for the doctors, that would be more confidential. And then the other thing that we did as part of these qualitative interviews was we pilot tested 15 quant survey questions, which I'm then going to turn and start presenting on now. And one thing I do want to flag, as you can see on the bottom, there were a number of papers that came out of this. And one of the things that's really exciting, and I just wanted to highlight here, are the number of papers. I just underlined folks that were at Columbia during the time of the papers. So this really was a group effort. And so Sadie Bergen, who many of you know, is a doc student in SMS. Kerrigan Parrish is faculty in SMS. Lizzie Kennard was project coordinator at the time. Sarah Reed was a master's student at Teachers College. Michael Vaughn was a postdoc at the HIV Center that I had the pleasure of working with. And then everybody knows Lisa Metch, who basically is my fairy godmother. So just really to say this is a team effort, and so much of it grew out of folks at Columbia. So I really just want to highlight that and thank people for being a part of that. So looking at these barriers and facilitators, one of the main things that came out is we kind of imagine this Venn diagram of, okay, so there's clinical eligibility, right? So this is viral suppression. But then obviously the main question is who's interested and who wants it. And that's sort of where I'm going to focus this talk today. But then there is these other questions, of course, of who can even get it, right? Whether it's logistically, financially, and then also who would most benefit from it. Because again, if people have to be virally suppressed to get on long-acting injectable ART, we're not effectively moving the needle. Yes, it's important to make sure they can stay virally suppressed and that things are, medication is as easy as possible. But in terms of some of the goals of achieving, ending the epidemic, we're not moving people who are not virally suppressed into that virally suppressed category. And so we sort of think about, okay, so who sits in the middle here, right? And who can we target? And then how do we move people from sort of the outer edges of the circle with the risk of sort of belaboring this figure, into the center, right? So we can say, and we're not trying to say everybody should be on long-acting ART. We're just trying to get to the point of if people want it, how do we get them to a space where they could access it and who could benefit from it? So given this background, some of the main issues and questions are around what does this look like in the real world, right? What do people think? What do they want? So given that, we took those 15 quant questions that we had pilot tested during the qualitative interviews, and then we did some additional tweaks to them as we got closer to approval. I cannot even tell you how many emails I sent around to faculty at Columbia trying to figure out how to ask about the pharmacokinetic tail. We did end up including the question because we thought it was important, but mostly the questions stayed based on how we had piloted them. So we then expanded this from the 6 sites that we had done the qual interviews to all 9 WISE sites. So the Women's Interagency HIV Study, which then merged with MAX, which was a cohort among men and is now called MaxWise. And this has been going on since the mid-90s. So it's the longest and oldest longitudinal cohort study of people with HIV and people without HIV in the US. And so we were able to leverage that. And so you can see the sites here. the sites that are in red are those that we were able to include because they were enrolling women. So this survey was done from October of 2020 until September of 2021. And I just want to highlight that date because the timeline straddled when long-acting art was approved. So we wrote the questions before it was approved. So some women were asked before and some after, but it was not readily available at that time. So it was still, and even at that, we sort of knew it was going to be approved, but these were still largely hypothetical. And so we were able to ask over 1,000 women with HIV, their thoughts on long-acting art, preferences, barriers to use, sort of where they would want to get it, who they would want it administered by, preferences for duration, and things like that. And today I'll focus on preferences. And then methodologically, we use logistic regression to determine factors that were associated with the likelihood of trying long-acting injectable art, and we controlled for sociodemographics. And so to highlight the sociodemographics we controlled for were study site, age, race, ethnicity, and education, drug use. We excluded cannabis. It's legal in a lot of states, so we wanted to make sure that was separate. And then self-reported adherence to oral art. And I do want to flag there were other variables that we had in the initial bivariate analyses that we thought might matter: time with HIV, viral suppression, depression, and income, but none of these were significant and so didn't make it into the final model. But I just want to flag, we sort of went back and forth about whether to include adherence or viral suppression. And we finally decided to focus on adherence because we were asking people whether they would be willing to try it. And we thought that might actually be based on how good they thought they were at taking their drugs versus actually what we were seeing clinically. So that was a conscious decision we made, but it's something we're still going back and forth now on additional studies that we're now doing. So the question that we were looking at and that I'll talk through right now is, how likely are you to try monthly shots for HIV medication instead of daily pills? Again, because this was asked in 2020 and 2021, the approval for the 4-week or the monthly shots was what was up for approval by the FDA. So we asked explicitly about monthly shots. And then we used a 5-point Likert scale. Excuse me. And then another set of questions that I want to flag, because I'll allude to them briefly, is we then wanted to do a head-to-head comparison. So we wanted to see both, would you try long-acting art? And then if you had to choose between monthly shots, daily pills, or you're not sure, which would you choose? And you'll actually see there are some discrepancies there. So I'm really glad we asked both. And so the results, and again, these are among women in MaxWise. As you can see, it's actually relatively spread out, about 20% per category, aside from the probably would not, which is about 12. And so then what we did for the analyses is we lumped the probably would and definitely would. And so it looks like, about 43% of respondents were probably or likely or definitely likely to try long-acting art. So a little under 50%. And so then we were interested in what is driving that. So when we did these adjusted analyses, I know there's a lot going on here, so I'm just going to talk you through it. So when you look at age, you can see that as people get older, they're less interested and or less willing to try long-acting art. We did not see any associations with education or race ethnicity. People with a history of the past year illicit drug use were more interested in long-acting art. And then people who are already adherent to their oral medication were less interested. And this, which makes sense, right? I think we've seen for other research on new modalities, younger people tend to be more interested or willing to try. And also people for whom their current medication is working, we don't necessarily, they don't feel the need to shift. So that tracks. One other thing I wanted to flag, which is interesting for the illegal substance use piece, is we had done qualitative interviews asking women who they thought could benefit the most. And they explicitly called out people whose lives are more unstable and highlighted drug use as being one of the issues. They also talked about younger people and people who weren't adherent to their medication. So it was interesting to see when you always see the synergy between quant and qual, it's really exciting. So that tracks. And then for site, we're still trying to figure out why this is. We have tried to lump these geographically, culturally, to try to figure out why everybody is different than Miami, which you'll notice is the reference site. And we chose Miami because we have used Miami as a reference site in other studies. For example, studies Lisa Metch has done through NIDA's Clinical Trials Network. And we're controlling for sociodemographics. So it's not just, there are potentially different demographics of women in these sites. So we're trying to think of it's maybe clinical culture, perceived access. So I just wanted to flag that that's something we're still trying to figure out. but we're working through it. And I also want to note, as I wrap up talking about this paper, Tara McCrimmon, who is a doc student in SMS right now, and I'm her advisor, led this paper that we actually got the email this morning that Jade's is sending us the proofs in the next couple of weeks, which was super exciting. So I'm really happy, so proud of her for taking this on and getting this one over the line. And then she also presented it at AIDS Impact in Sweden last year. So then after looking at that, we thought, okay, so we were thinking about likelihood. What happens if you do this head-to-head comparison? I'm not going to go through the details, the multinomial regression. As you know, that could be its own like half-hour presentation. But I really wanted to just note that when we did these head-to-head comparisons in a multinomial regression of long-acting art versus oral art, long-acting art versus undecided, oral art versus undecided, we were particularly interested in the undecided group because if somebody says, I want long-acting or I want oral, great, like they know what they want, and not that those can't change, but they have a pretty good idea. But this undecided category was particularly interesting to us because we feel like those are the people, it's like undecided voters, right? They're the people that can shift over time. So when we ask people, you'll see, again, about 43% preferred long-acting injectable art, which actually aligns almost exactly with what we saw earlier, which was 42.8% who said they were willing to try. So those actually really align quite closely. But a little more than 20% are undecided. And so we wanted to just get in and explore that a little bit more. And I'm just going to show a couple slides briefly as we're trying to figure this out. I mean, the paper's in the works. And I've struggled with it more. By in the works, I mean, it's sitting in my to-do list, but I've really struggled with the discussion of sort of why, right? What are we seeing and how to kind of address this undecided category? So just briefly, I wanted to show you variations in being undecided by site. And you can see they range from about 12% in Atlanta. So in Atlanta, not a high, most people know we're very clear on what they wanted, but in Jackson, it's almost 30%. And so there are reasons we could think about, maybe you'd say, okay, so stigma's higher in the South, medical mistrust higher is in the South, but Atlanta's in the South too. The demographics are relatively similar in Atlanta and Jackson, though Jackson is a little bit more rural. But just to say, like, it is interesting to see these divisions. And so we're trying to think through what might be driving some of the differences. San Francisco also was almost, 27% were undecided. So those aren't that different than Jackson, for example. So just to say, this is something that's coming up a lot and we're hearing clinically too, people who still just kind of want more time to think it through. The other thing, and just before I wrap up this section and move on, is that there were also variations in sites and and whether when you ask someone, would you like long-acting injectable or oral pills? So it's interesting, you can see in Bronx, Brooklyn, so the sites with green, Atlanta and Jackson, their participants really preferred long-acting. They really wanted shots more than they wanted pills. When we asked that head-to-head comparison question, DC, San Francisco, Cook County, and Chapel Hill were sort of in the middle. And then Miami, which makes sense why we're seeing such a difference with them as the referent group, really preferred pills over shots. So it's interesting, again, right? We need to think through why this is. I'm doing focus groups now in Miami as an extension of the study. And there's a high levels of skepticism around long-acting art. Only one woman in the focus group had tried it. She went off after 3 months. But yeah, just to show you, we are seeing geographical variations, but not necessarily in the way we would think in terms of it clumping by, say, geographic region. So again, just to flag, like that's effectively a 40-point swing, right? So we're seeing a lot of differences by site. And just to say, when we have that scale up, we need to think about what that means, particularly when there are challenges in, say, states that did not expand Medicaid and getting them, how to bring people along. So to wrap up and thinking about implications for scale up, we did see women had lower levels of enthusiasm than in the clinical trial settings, where it was about 95% of people said they'd prefer long-acting art, whereas here it was about 50. And then just over a fifth of the women were undecided, which is a quite substantial group. So really making sure providers have ongoing conversations, because obviously preferences can change with time both ways, right? Somebody may want long-acting and then they might want to switch back. So just checking in to see how meds are working. And obviously no one is saying that long-acting art isn't beneficial. It really is, but there are potential disconnects that we saw between who's interested, right? So people who are younger, who are not virally suppressed, who are using illegal drugs, and then people who are currently eligible, right? Who have to be virally suppressed, and not just eligible, but who are likely to be offered it by providers, which I'll talk about in the qual section. And then really, and again, I know I'm preaching to the choir on this one, but we need active programming and interventions to really support women's choice. And I notice I'm saying choice, right? I'm not saying so we can get people on long acting. This is just another tool. It's super exciting. We have it. And we need to make sure that people feel comfortable saying to their provider, I want this, and making sure that their provider listens to them. So continuing this thread, so as we're wrapping up, as we're continuing the analyses from Max Wise, in the interim, actually, we took some of these same questions and administered them again through another cohort study. So it's called STAR, so it's the study of treatment and reproductive outcomes. And you'll see from where I circled, you'll notice this map looks familiar. It's the map of the Max Wise sites. And then the ones with the blue dots in the middle, so Washington, D.C., Chapel Hill, Miami, Atlanta, Birmingham, Jackson, are also STAR sites. And so what they're doing is leveraging some of the Max Wise infrastructure, but recruiting women of reproductive age, so 18 to 45. And so we were really interested in this for a couple of reasons. One, as I noted on this slide, it's because we can now ask people. We started administering these in January of last year, January of 2023, as long-acting ART has been, been on the market for a little while and is approved. And I just want to flag the PIs of this are Nandi Sheth at Emory and Maria Al-Qaeda at University of Miami. And then I'm leading work on this with Dr. Lauren Collins, who's an ID doc and assistant professor at Emory, and she also runs their long-acting ART clinic. So it's been wonderful to collaborate with her and really have an ear on the ground. So just briefly as an example, in terms of scale-up challenges, when they started, the Excel doc wouldn't, they couldn't get it to sync with, so they couldn't get the documentation to sync with Epic, so they had to record everything on an Excel doc. They didn't have the needles that were long enough for people who were overweight, so they were ordering them on Amazon. Medicaid wasn't expanded. So a lot of people who were on Ryan White were coming in asking for long-acting ART, but that wasn't covered by it, and ViV's patient assistance program wouldn't cover people on Ryan White. So you're getting the most marginalized people coming in asking for this new modality, and the providers are having to say they can't have it. So just to think about what that means for medical mistrust and some of the geographical disparities we might be seeing. So briefly, why STAR, right? Why this study? And we think that young women have really unique life circumstances that likely affect their perceptions. And just so you can see briefly, I'm not going to belabor the differences, but the median age is about 15 years younger in STAR than in Max Wise. The racial ethnic breakdown is relatively similar. Income is a little bit higher in STAR, though still relatively low, with about half the people making less than $24,000 a year as household income, and then about 80% are adherent. So it mainly is the younger age that is the difference. And so because we really were interested in what people of reproductive age think, given that pregnant people were not included in the trials. And STAR will eventually have about 2,500 participants. And so we're really excited over time to see the data we get from there. So as I said, the questions that we included in this section were based on those we had administered in Max Wise, because we really want to be able to compare the findings across the two studies. But we also updated it because once we had started administering in STAR, as I mentioned, long-acting ART had been approved by the FDA for both monthly and 2-month dosing intervals. So we wanted to make sure that that was captured. And in addition to asking about some of the things you see here that we also had in the previous study, so things like likelihood to try and preference for pills, prior history with injection, ease of getting to the clinic, where they wanted to get the injection on the body, who they'd want to have give it to them, and then benefits and barriers. The main two new sets of questions were concerns about the potential impact on sexual health and reproductive health. And so for the purposes of today's talk from the STAR data, I'm going to focus on likelihood to try or preference. So those same questions that I showed you earlier, how likely are you to try long-acting injectable ART? And then in a head-to-head comparison, would you prefer long-acting ART, oral ART, or you're unsure? And then I'll present briefly some data around concerns around reproductive health. So again, this is super preliminary data, so take it with a grain of salt, but I just wanted to share because we are seeing differences from what we saw in Max Wise. So there have been about 250 of these that have been administered so far, but they're not all clean. So this is what we got from the last data dump in the end of December. And we just submitted a short report on this that's under review right now. So when we ask people how likely they are to try long-acting ART instead of daily pills, you see a very different breakdown. So remember in Max Wise, it was 43% of respondents said they were probably or definitely likely to try. And here we're seeing 65%. So that's a pretty big difference. And, there are many reasons this may happen. Again, we saw that in the original study that we saw the people who were older were less interested. So this is a younger cohort. We're also asking these 2 years later. So it may just be that people feel more comfortable. They've started to see friends that have been taking it. But it is interesting to see that shift, that people are more open to it. And then when we did the head-to-head comparison, we really do see a difference here. So again, before it was 43% of women in WISE who wanted long-acting ART in this head-to-head comparison, and here it's 63. So we thought that was particularly interesting to see that shift. I want to note of the 103 women that were interviewed for this, 3 of them are on long-acting ART, so not a high number, but to flag there are some. And then what's interesting here was, so we saw 22% that would prefer daily pills, which again is what the majority of them are on, 100 out of the 103. But then you still see 8% that are unsure and 6% with no preference. So, and then 1%, which was one person who just, they don't want HIV treatment regardless. But it's about 15% that are still in that kind of not sure, figuring it out category. So there are still people, that are in this space of trying to decide what they want, which again goes back to the importance of patient-provider discussion. So what I want to shift to now is we had asked 6 questions. So I'll show you 3 now and then 3 in the next slide, just to not throw too much info at you on a slide. So we asked women about potential concerns around reproductive health. And so just to kind of orient you to the slide, the leftmost color is the dark blue, are not at all concerned. And then if we move to the lighter colors, the green is very concerned. So what you'll see here is for these first batch that, they're 34%, or if you lump somewhat and very concerned, 42% that are afraid that long-acting ART may impact their future fertility. And again, because we haven't been able to study this because of who's included in the clinical trials, which again, I understand the point of clinical trials, and this really does need to be tested. So a large chunk of the population, given worldwide that, the burden of HIV rests largely in women worldwide, and then in younger women within that group. And then also whether it would affect birth control. And so that's something too we have to think about of, are there women that might not be willing to take this or may stop showing up for appointments because they're afraid it may cause them to get pregnant. So again, making sure we have these conversations with people up front. And then the other 3 questions was questions about, would it affect your baby if you're breastfeeding or chest feeding? And again, about 35% were very concerned or somewhat concerned that it would. And then safety issues for you or the baby. And then there was less of a concern about potential impact of trying to get pregnant, but still a third of, 30 people, which is definitely something to think about. So just to show all of these together, I just wanted to flag the ones that had the highest number, almost 40% of people thinking they were somewhat or very concerned. And it was around future fertility, or then what would happen to you or the baby if you're pregnant or breastfeeding or trying to become pregnant. So just to highlight that it is really important for providers to have these conversations, for information campaigns, to make sure we think about reproductive aged women or people who can get pregnant as we are having these discussions. And so in terms of next steps for the research in STAR, we're continuing to administer these. So I mentioned there are 2,500 women, and these are people assigned female at birth. So 1,500 of them will be with HIV, and then 1,000 are without HIV. So I just want to flag too, in addition to what I talked about today, we're also asking about additional long-acting formulations. So things like patches and implants, and then injection windows. So what would happen if it were every 3 months, every 6 months? And then we also ask questions about long-acting PrEP, which we're excited to start to explore. We're talking about doing qualitative interviews with sort of early adopters, which is funny to call them early adopters since it's been on the market for a couple of years. But given that uptake has been relatively slow, to see how people decide to get on, to stay on. And then these data, actually, we got really lucky. We had already started doing them, and then we're able to leverage them for a CDC grant, which I'll mention briefly towards the end. So I want to shift from sort of the quant data, which this was both sort of temporally how things happened, but also in sort of thinking through what informed what. We were looking at these quant data and thinking, okay, so we've talked to the people who are living with HIV. We're interested in hearing from providers about what barriers they're experiencing. and then how they don't resonate with what we're hearing from the women that we interviewed. And so, as you've seen, like, clinics are scaling up long-acting art, but there are these sort of long-standing social inequities that are unfortunately like baked into the US healthcare system and into the US more generally that have challenged, medication uptake, adherence, particularly among minoritized and marginalized individuals. There are also clinic level barriers to scale up. That's a separate paper that we did, which also Tara McCrimmon also led and got published in AIDS Patient Care and STDs, I think in January. Yeah, so she's just like rocking it as a doc student, which is amazing. But today I really wanted to talk about how providers decide who to offer long-acting art to. So again, as we saw in these head-to-head comparison questions, women would like access to multiple types of modalities, but access is in part determined by medical providers, right? They prescribe treatment, they help patients choose between long-acting art and oral art, excuse me, and they decide whether or not they even give somebody an option. And so given that, we explored how providers determine which patients they consider to be candidates for long-acting art and how this may influence who's offered long-acting art. And so these studies happened from 2021 to September 2021 to March of 2020. So this was after long-acting art had been approved, though it was not fully scaled up. So about half of the clinics we spoke with had already had a program going, but about half did not. So these interviews occurred across 6 different cities. We did want some geographic diversity, more around north-south, and that was due more to services and Medicaid expansion, also potentially some clinical culture differences. And so we used purposive sampling, in part because we wanted to get a range of research centers, private clinics, and publicly funded clinics. I think so often in our research, we default to academic centers or Ryan White clinics. And so we actually really worked hard to talk to people who were running, their own clinics, sort of one-off spaces, and whose majority of their patients did not have HIV. And so we really asked them, who do you offer this to? And I put the term ideal candidates in quotes because that's something that came up in the interviews. They'd be like, who would be an ideal candidate? But really that's what we're interested in, right? Like, who do they think is sort of quote unquote the best fit for this? And then how does that affect who gets offered it? And so again, we interviewed 38 providers. And before I go into the demographics of the providers, I just want to give a huge shout out to Tara and Michael Vaughn, who did the majority of these interviews, who really, like, especially because this was in the middle of all of the COVID crazy, just rocked it and did an incredible job. And then also supported the qualitative analysis too. And so in terms of the data collection for the interviews, they were 45 to 60 minutes, and we recorded and then uploaded them into Deduce, and then used thematic content analysis to do, to kind of figure out what was coming up for providers and as an analytical framing. So one of the things I wanted to share here with this figure that you can see, most of the people we talked to were physicians, though we really did try to get a range of not only other medical providers, but also people who are providers but non-clinicians. So pharmacists, case managers, and clinic and community coordinators. And then one thing too about the years providing HIV care that I wanted to share is most people had been providing care for at least 5 years. A lot of them had been providing care for a long time. And something I'm not going to talk about today, but that came up was providers who had been giving care, providing care for probably 15 or more years. They were actually the ones that were most nervous about it because they were like, listen, I remember the days when we were trying to give people, 5, 7, 10 pill regimens, and it was really hard. Whereas some of the newer providers, they're used to 1 pill once a day. And so I think some of the providers who had been around longer were actually more nervous about long-acting art. So there were 3 main themes that came up, and I'm going to give a couple quotes as examples of each. So one was generally about the eligibility concerns, right? That it was only approved for people who are virally suppressed. And one was shifting the focus from who will take a pill to who will show up for a care visit. And then the third were how structural vulnerabilities affect long-acting injectable use. So one of the main things that came up was that, people with detectable viral loads could benefit the most, but they weren't eligible. And so a case manager in Atlanta said, listen, I don't agree it should only be for patients that are suppressed. The target should be those patients that are not doing good. And so really this idea of who's going to benefit and how do we get the access to them. And a physician in Atlanta sort of also backed that up by saying, listen, I'm just not sure the label is serving those most in need. So really physicians are identifying that too. And as we're seeing now, like I mentioned, a shift to providers actually just using it off-label with people who are have a detectable viral load, though at the time there were still providers were more reticent to do that at the time of the interviews, I should say. And then the other was providers were wondering, listen, maybe the FDA is just doing this because it takes the burden off providers, right? Then we don't have to make the clinical call of whether this is a good idea. And so a provider in Pittsburgh said, listen, I think the viral suppression requirement makes it easy from a provider standpoint. It's very simple. Someone can make that switch from oral to long-acting ART without necessarily understanding the intricacies. It's foolproof. Right. So basically saying like you can do this for providers. One other thing I want to flag, and I'm not going to go into details since I'm not a clinician, but like I said, long-acting ART is cabotegravir or pivirine. So it's a 2-drug regimen where a lot of the pills are 3-drug regimens. So there's fear it might be a little less forgiving if people do miss it. And so that is something providers talked about is because it was a 2-drug regimen that they were a little reticent when they were to give it to people who they didn't think would show up for the clinic, which was the next theme, right, of patient attendance at HIV care visits. And since again, long-acting ART requires more frequent visits than oral ART, someone who's virally suppressed on oral ART may show up every 3-4 months, even 6 months. They can get their pills in the mail. Providers really focused on clinic attendance versus medication adherence. So a pharmacist in Jackson said, listen, over time, we've seen some patients who consistently come to appointments and they would be great candidates because they can't take a pill every day, but they can come for appointments and get an injection. So that was really the focus of providers trying to sort out in their head who would fall into that category and who might be a, quote, an ideal candidate. And then providers also really talked about the importance of knowing a patient well. And so a physician in Atlanta said, so an ideal candidate, they want to stay in care, they're committed to treating their HIV, they're tired of taking a pill every day, and I can count on them to come in every 2 months. And I don't worry too much about them being lost to follow-up because I've known them for 10 years, right? So they really stress this personal interaction, which may actually limit who they're willing to offer it to if there are people they don't know as well and they feel like they can't guarantee will show up. And then the third theme that came up was this question of structural vulnerabilities and how that might play into adherence to long-acting ART or adherence to clinics visits. And providers really talked about long-acting ART as this potential solution to address structural vulnerabilities that had challenged oral ART adherence, including things like substance use and housing instability. And they also talked about not only could it really benefit them, but it was something that made them reticent to actually offer long-acting ART to somebody. Excuse me. So the nurse practitioner in Jackson said, she's an opiate user and her life's been very disordered. She herself said to me, quote, I'm terrible at taking pills. And I was thinking, oh, wow, wouldn't it be nice if I could just give her a shot? But I'm in no way convinced I could find her once a month. So I'm not offering it to her. It makes me sad. It could potentially serve her purpose so well, but I just won't do it. Right. So that nurse is really struggling with this balance of who could benefit the most and who's eligible and who do they think will come in. And then the last structural vulnerabilities quote that I wanted to share was that providers really talked about 3 distinct drivers underlying patient care engagement and whether they show up to the clinic. So this included external responsibilities like childcare and work, organizational skills, and motivation. And so a physician in Pittsburgh shared, look, for a lot of my patients, it's just not feasible because of their work schedule. One who was on long-acting ART went off it because after a couple of months, he was like, this is really hard. Every time I'm scheduled to come in, my shifts change. So I think the ideal patient would be a person who's reliable with a flexible job that lives next to the clinic. I'm like, I mean, great. Wouldn't that be lovely for all of us with doctor's appointments? But, when you hear them describe the ideal patient, you're like, yeah, that makes sense. But like, is also not necessarily what most patients are going to look like in terms of a flexible job, that's right next to the clinic and ability to easily come in. And then one last quote I wanted to share, which is not about structural vulnerabilities per se, but was interesting because of some research we're doing right now, was this fact that providers really saw women as more likely to adhere to long-acting ART than men. And this came up consistently, that they saw women as sort of more reliable, more organized, having to balance childcare and still show up. And so, one of them really said, I think if women are on shots for birth control, then it would make it easier for them to switch to long-acting ART. I think women would do better. And it's interesting to think about that. And so we actually then, based on this quote and some other conversations we've had with people at NIDA, actually looked at that and we're like, all right, do we think, and we, is there an association? And so we've actually looked at this around long-acting injectable PrEP, and we did find an association with, so people with a history of depot use for birth control, so the long-acting injectable form of birth control, were actually more willing to try long-acting PrEP than those without the history of depot use. And we're doing those analyses now for long-acting ART. So again, thinking about the synergies of quant and qual, it was actually really helpful for us to do this. And then, I mean, we just did these analyses. We're actually submitting it to R4P. So like, in process, right, that they're able to really inform each other. So in terms of the qual findings, clinical eligibility was really important, but it was definitely not the only factor that determined who would be offered art. And then we found disconnects between the patients who providers thought could most benefit and then those who were clinically eligible. And providers noted specific patient characteristics that they thought could make them strong long-acting art candidates. So that's regular clinic attendance, organized, motivated, history of injectable birth control, and long-term relationships with providers. And then they also noted that many of the people who face significant barriers to oral art adherence might also face barriers to long-acting art adherence. So meaning, it would help, but it's certainly not going to be a panacea. And then providers describe potential tensions between using long-acting art as what they talked about as a carrot, like, hey, if you get virally suppressed, we can put you on long-acting art. And then really feeling like that set this dangerous precedent in a power dynamic, right? Of being like, if you do the thing, I'll give you this fancy drug. But they really were afraid of what that might mean for medical mistrust with them and their clients that they served. And then just to remind, to flag this again, like long-acting art is being increasingly prescribed to patients who are not virally suppressed. And so we really need to keep doing work both from the clinical side to see how that plays out, but also with the people themselves to see how they feel about making that jump. So as I start to wrap up the presentation, I just want to highlight where we're going from here. So the provider interviews I just described and the work in Max Wise as part of an R34 that I'm leading. And the main goal of that is to develop a patient decision aid. So we're in the stage right now, we're doing focus groups with people in Miami. We have a paper version of the decision aid that's finalized, and we're starting to move it into an electronic version. And the goal of this is really to help women and their providers choose between oral and long-acting art, and to make sure that women can make values-based decisions and feel comfortable saying, this is what I want based on my experiences. So helping to increase agency within patient-provider interactions. And then the other thing too is the CDC grant I alluded to. So the questions we administered in STAR, so among women of reproductive age, are also part of a CDC grant that Dr. Lauren Collins and I are leading, where we're developing tools, and we're still trying to figure out exactly what those tools will look like, but that's a year 3 of the grant problem. We're still in the beginning phase. And we're to help women in the South have increased access to long-acting art. And so we're going to be using human-centered design processes to develop those tools. So that's going to happen towards the end of year 2 and then all through year 3 to really think about what's helpful for the women, for the providers, to really make sure people have a full understanding of the variety of options and then to increase access. So the last 3 slides before I wrap up, I just want to give a sneak peek on some of the work we're doing on long-acting PrEP to get a sense of where that is going. And interest in the Max Wise was quite low, which you'll see. And we also inserted questions into STAR and are excited to see what we see there, right? Because we think interest is probably going to be higher. So just briefly, why women in long-acting PrEP? Women's PrEP use on average is shorter than men's. And there was the CDC released data a couple months ago that in 2020, only 15% of women who could benefit from PrEP had access to it versus about 40, I think it was 41% of men. And then women face some unique barriers, right, around gender and power dynamics, pregnancy, because again, the long-acting PrEP trials did not include pregnant people, caregiving responsibilities, labor market, and the medical mistrust due to the history of sterilization campaigns. And some of these directly impact young women, which is why we're really excited to see the STAR study results. So briefly, this is from the Max Wise study again. So this is slightly older women, and this was done in 2020, 2021. And there were 480 women who did not have HIV that we asked this question of about willingness to try PrEP, long-acting PrEP. So you say about half say definitely not. But, a little over 20% so they'd probably or definitely try. So there's some, but again, interest is overall relatively low. We started to look generally at correlates. There were some with sites that we're still trying to figure out exactly what that means. And then sexual and gender minority individuals were more interested in long-acting PrEP, people with depression, and then some are high perceived HIV risk, whereas Latinx and Black women versus white women were less interested. And then when we did the head-to-head comparisons, we saw that about 30% were interested in long-acting injectable PrEP, versus 22% for daily oral PrEP. But again, to highlight this undecided or no PrEP regardless of formulation is over 50%. So they were just not having it at all. It's just not something they felt was useful to them, that was relevant for their lives. We saw this in the qual. And so just again, although we think we did just run the brief descriptors in STAR, and it said a 64% would prefer long-acting over oral daily pills. So think about, so 63 versus what we're seeing here is 30. So we're seeing a huge jump. Again, this is like 100 women in STAR, so I don't want to make any grand statements, but we are seeing discrepancies, which is exciting because it means that people are more interested in other and open to other modalities. And then we're looking at predictors of this. So, and one of this is for IS presentation, so we're excited. All right, so just wrapping up, one of the things I do want to highlight is some of the work that's being done to really get people into the fold, right? And by that, I mean helping support them to achieve viral suppression. So many of you know about the Latitude study, which is focused on long-acting ART among people with a history of challenges to oral ART adherence. So it worked with people struggling with adherence and then offered high levels of support so they could maintain viral suppression and then be randomized to take long-acting ART or oral ART. And then, as many of you know, they actually recently shifted the protocol because the DSMB found in the data review that people in long-acting ART were doing much better. So that's super exciting, right? We're seeing some shifts as a result of the real world. But there are a few things I just want to highlight as we wrap up. So it's really important to make sure we include pregnant and breast and chest feeding individuals, as well as youth in clinical trials. We need to keep studying the use of long-acting ART among people who don't show up to the clinic and who are not virally suppressed. We really need to think about creative strategies to improve medication adherence, including considering direct to inject for people who are newly diagnosed. And we need to start thinking about how we can offer non-clinic administration of injections. So thinking community hubs, mobile units, even training for self or partner home injections. So basically, get long-acting ART to where people are. Maybe adherence clubs could be beneficial. We've seen that in the past. And then it's also critical to support implementation in low resource settings, considering supply chain issues and the need for refrigeration and viral load and resistance testing. And then we need to keep the pipeline open for novel agents and delivery systems to really make sure this is feasible for everybody. So finally, long-acting ART really has incredible promise for shaping the course of the epidemic. I think we all agree on that. And it's only going to reach its full potential if we facilitate an equitable scale up. It needs to be available to everybody, regardless of viral suppression. And we also have to change the social policies, right? Make sure Medicaid expansion is a thing to ensure that people who want ART can, long-acting ART or ART in any form, right, can access it. So I just want to end with an acknowledgement slide. This is obviously packed because there's so many people that have helped throughout this process. And I'm absolutely in debt to them. And I really want to thank the people who took the time to be interviewed and to answer the surveys, and then to the funders. And thank you to all of you for sticking around for this presentation.